you don't really know, you don't have the full history, you don't have a physical exam. And so having that summary of like the ongoing events is going to be important. And I'm probably going to ask one of you guys to summarize the case for me at the end. So just keep that in mind. All right. Okay. Any questions before we start? No? Okay, cool.
I have a question.
What's up?
So the notes you told us to for this case, are these the ones which we have taken before, like coming to this session, or there were two kinds of notes we have to submit?
Yeah. So don't worry about submitting the notes now. We're gonna do that later. You don't need to submit anything for this week. If there's a due date for this week, don't worry about it. We'll change that. You're not going to have to submit anything until the end of this month, actually. So don't worry about it for now. Just take the notes that you need for the class, and we'll go from there, okay?
Okay, thank you.
No problem. Any other questions? All right. So we have a 45-year-old female with a history of hyperlipidemia who presents with sudden onset upper abdominal pain for the last 8 hours. She states that she's had intermittent sharp pain over the last week, and the pain that she had in that last week would usually resolve on its own. But this pain has been different. It's been ongoing for 8 hours. It's not getting any better. It's actually getting worse. So, Dr. Sexton, what are your thoughts? What are you thinking of with her initial history?
I'm sorry, what was the question?
So what are your thoughts of that first statement, her initial history? What do you think is going on with her, or what are some questions that you would want to ask her?
I would want to ask her about if there have been if she's traveled recently, and then any other, if it's possible she could be pregnant, if she's felt any fatigue, and then just I would want to do a physical exam on her abdomen area.
Okay, so you're saying that you want to know if she's traveled anywhere. What are you thinking of with that?
It could be like gastroenteritis or some kind of bacterial infection, and it could also be like possibly hepatitis.
Yeah, so definitely. So with the travel, if she's eaten anything out of the ordinary, if she's eating like food from like street vendors or anything like that, especially if she has traveled, that can definitely cause her to have something like gastroenteritis or food poisoning. Pregnancy is also a really good question because, you know, she's 45, so she's a little on the older side, but still, I mean, you're 45, you can still get pregnant. I think the oldest mother that I've delivered was, I think she was 51. So you can definitely still get pregnant at 45. And so, yeah, so you'd want to ask about that. You'd probably want to get a urine pregnancy as well. So what about the pain in the upper abdomen? What are some of the things that can cause that pain?
It could be from like gallstones or like an ulcer or something with the stomach, the liver, or the gallbladder.
Yeah, so stomach, you said stomach, liver, gallbladder, anything else?
The heart, possibly. Or the pancreas.
Okay, yeah, so heart, pancreas, the lungs are also in that area. Yeah, I think you got pretty much all of them. I think somebody mentioned the spleen as well. So yeah, definitely in the upper abdomen, epigastric region, you can also have some splenic pain, but that's usually going to be in the left upper quadrant. But you know, it's all in that same area, so you can definitely do that and have that pain too. Okay, good. And if this pain is similar to the pain she had in the past, let's go with Dr. Hidari. If this pain is similar to what she had in the past, what is it that is going to be important to know?
So maybe since she's had this pain in the past, like I might be thinking that it's like a developing pain, so it could be getting worse because before, like she said it got better on its own, but now she had to come in and she wanted, I mean, I guess it got worse to the point where it was for 8 hours.
Yeah, so there is some type of chronicity to it. She was having this in the past, over the past week. She's been having it pretty intermittently, but now it's happening for the last 8 hours without any relief. And so, one, we're going to want to know, you know, how often was she having it in the past, and if there's any differences between now and then. But, you know, if this is similar to what she's had in the past, that tells us that there's likely that whatever pain she was having, if it was similar enough, that maybe this is getting worse. Maybe there's now an acute problem on that either chronic or subacute problem. Does that make sense?
Yes.
Okay, good. And so what would you want to ask her about the pain she had in the past?
So maybe like how, like did she do anything to make it better or worse?
Good. What else?
And then if she tried, like whatever answer she had to making it better or worse in the past, like if she tried that now, and if it made any difference.
Good. So she would try Tylenol in the past. It helped a little bit, but it would generally just go away on its own. She tried Tylenol this time, didn't really help. And Dr. Hannah's asking if it radiated anywhere. It doesn't. What else would you want to know?
So you said she took Tylenol this time too. So I would want to know, well, she has chills. So maybe I was thinking that she had some kind of infection. But I don't know her temperature, and it said she didn't have a fever. So maybe I would be thinking like if she took Tylenol this time, like what effect it had.
Yeah, so exactly. So, you know, she took Tylenol in the past. Maybe that helped. Maybe it didn't. And she's saying it didn't this time around. You know, she's saying that she didn't have a fever, but maybe if she was taking the Tylenol for her pain, it might have been masking a fever. So good. What about, so I don't know if you touched on it and I might have just missed it, but I think you asked about like what made it worse. So one thing that I would typically ask is like, what was she doing right before the pain started, right?
Yeah, so maybe I want to ask if it was caused by her diet, because she does have hyperlipidemia, so maybe she's having like a high fatty diet. So maybe if it was caused before or after eating or while eating.
Yeah, good. So what if I say that it happened after she ate, what would you be thinking of?
If it was after she ate, maybe I was thinking like an ulcer.
Okay.
Because the stomach will produce more acid, and then maybe that will cause the pain.
Good. If we say it's an ulcer, but it gets better after eating, why does that happen?
I'm not sure.
Okay. So an ulcer in the stomach will typically be worsened by food because you're going to be producing more acid. You're going to be exposing that ulcer to more gastric contents or gastric acid, and so you're going to have more pain with that. Same thing with if you had like esophageal ulcerations and you have reflux, although those are less common. can you think of anywhere where you would have ulcers that would make it better when you eat? And if you can, why does that happen?
I know that the stomach produces acid when you eat, and then the pancreas is going to like produce buffer to neutralize the acid.
Good.
Maybe something to do with that, but I'm
Yes.
not too sure.
Yeah, exactly. So your pancreas is going to produce that buffer, a little bit of that base to neutralize the acid. So because you're after the stomach, you have your duodenum, and so your duodenum is not used to seeing the acid of the stomach. It's not meant for that. It doesn't have that same mucosal lining that the stomach has, and so you're going to need to have something to prevent from basically burning through your duodenum, and so that's what your pancreas does. Your pancreas creates that buffer for you. So after you eat, your pancreas is going to be stimulated as you're eating to produce that buffer, so that when your gastric contents are dumped into the duodenum, you neutralize that acid. And so if it gets better after you eat, it's because the ulcer is not really exposed to that more acidic environment, because the pancreas is helping buffer that out. So good job.
Thank you.
Okay. So all right. So Dr. Saya, when we're talking about pain after you eat, other than an ulcer, what else can cause that type of pain?
Inflammation
Of what?
of the stomach.
So like a gastritis, maybe, because you're going to have more acid. So potentially, what else?
Could it just be like indigestion or?
Maybe, but it's going to be specifically after you eat, right? So what are some things that happen when you eat? So we talked about the pancreas helping out. So if the pancreas helps out because it excretes some of these enzymes and buffers as you eat, can the pancreas cause abdominal pain after you eat?
Mm-hmm. Because
Okay.
I was thinking more of like a GI thing or
Okay.
GERD.
Maybe, yeah. So after you eat, you can have some reflux and some heartburn. That's typically going to be in the chest and coming up like to the esophagus. Not so much in the epigastric region, although you are right. Actually, let me back up. It will cause epigastric type pain, but not necessarily vomiting like she was having.
I had a quick question. It says that she
Yeah.
takes Claritin. Isn't that like for her allergies? So could it be something related to like a food allergy or?
Typically, Claritin would be an allergy, like environmental allergies, not so much for a food allergy.
Okay.
Yeah. Food allergies, you typically will have either a rash or you can have like anaphylaxis, which is basically your airway closes up because of the inflammation, but not necessarily, you wouldn't necessarily use Claritin for that.
Okay.
So the pancreas, and if somebody had pancreatitis, inflammation of the pancreas, you can have abdominal pain after you eat. So what I usually see though is that patients won't want to eat because every time they do eat, they'll be vomiting and they'll have some abdominal pain. So I usually see the vomiting more than I do the
Abdominal
pain.
pain. Okay.
But it is possible. Well, there's a lot of. I didn't realize that there was a lot of comments, and my thing didn't scroll. Okay, oops. So all right. What else other than the pancreas?
I don't know.
Okay, that's okay. Dr. Musa, what else?
I'm thinking gallbladder.
Okay, gallbladder. Good. Why?
Because the specifically after eating, it might be because of the breakdown of fatty foods and the lipids. So that may be causing pain. Because if there's like for gallstones, if there's a blockage, some of that might be causing the pain.
Good. So as you eat, what happens to the gallbladder?
I'm not sure, but it breaks down the fatty foods.
So yes, so the gallbladder has bile, right? It stores
Yeah.
your bile, and so it needs to release that bile. So as you eat, what do you think the the gallbladder is going to do?
I'm not sure how to explain.
It's okay. So you have this little, like, let's pretend this is your gallbladder here. You have this stack of bile, right? And so as you eat, it's going to stimulate your gallbladder to contract down to push all of that bile out. And so if you were to have a stone that's obstructing this outlet right here, as it tries to contract down, that it's not going to go anywhere, right? You're not going to be able to push that bile forward. And so it's going to cause inflammation of the gallbladder wall. It's going to cause stagnation of the bile. You can have, eventually you can have an infection of that area. And then you can also, if it gets bad enough, you can have perforation of the gallbladder. You spill your bile into your abdominal cavity, and that's never good, right? So, so as you eat, that you're going to start to stimulate that gallbladder to contract down. It's usually with fatty type food. So if that patient tells you that that morning they had eggs, they had sausage and bacon and all the different fatty foods that you can think of, and then they're having pain, you're going to want to think of something like inflammation of the gallbladder, gallstones, or cholecystitis. Does that make sense?
Yeah.
Okay, good. All right. So, okay, so it says that she had pain in the mid-upper abdomen. It was sharp. Sometimes feels like cramping. Usually occurred after she ate and lasted anywhere about 5 to 15 minutes. But now it's happening for 8 hours. It's not getting any better. So this morning she had 2 episodes of non-bilious, non-bloody vomiting with the onset of pain. So Dr. Marie, what are you thinking about when with if somebody comes in with bloody vomiting? What do you think of?
I would, if it was bloody vomiting, I would probably think of potential like esophageal mucosa or ulcers.
So ulcer is one. Anything else that you can think of for with bloody vomiting?
I would be interested in the color as well, whether it's like bright red or like a dark color or like a coffee ground.
Good. So exactly. So if it has time to mix with the gastric contents or the gastric acid, you can definitely have that seedy coffee ground type vomit. What if it's just like pouring bright red blood? What are you thinking of?
Wouldn't that be like upper GI?
Mm-hmm.
Because it would not have the time to like kind of like mix.
Exactly. What if I told you that this patient has a history of cirrhosis, and had it for years, and now it's coming in with just profuse bloody vomit? It's a hard question, so if you don't know, it's okay.
Does it have to do with the liver?
So cirrhosis, yeah, it's basically liver failure. One thing that you get with cirrhosis is so you have your blood vessels that go from your intestines to your liver. So that takes all the nutrients from your gut, and it gets transferred up to the liver. And so what ends up happening is, as your liver becomes more scarred down from the cirrhosis and becomes more fibrotic, you have a lot of resistance in that blood flow up through the liver back to your heart. So it starts to back up into the other to the venous system throughout the rest of the gut and the rest of your body. And so you will have something called esophageal varices, right? So that back pressure is going to cause the vessels to dilate, and you'll see those dilated vessels in the throat and the esophagus. And so if somebody had a history of cirrhosis and they started vomiting blood, the first thing you want to think of is varices or dilation of those veins in the throat, because that could be ruptured pretty easily and you'll just start pouring out blood. Yeah. So I think Dr. Nima saying esophageal varices, however, she denies alcohol use. Definitely true. She denies alcohol use, so it's probably not that. Could an obstruction happen? So like a bowel obstruction, maybe. But so if you had a bowel obstruction, that would be that second part, that bilious part of the non-bilious, non-bloody. So if you have a blockage of the intestine at some point past where the bile drains into the intestine, that bile typically flows downwards and helps, digest your food. But if it can't flow downwards because there's an obstruction, you're going to have a buildup and you're going to start to vomit that up. So that can be a cause of bilious vomiting. All right. So she can be lying about alcohol use. Yes, definitely. But for the most part, we're going to take her word for it. Non-alcoholic causes cirrhosis, like Hep C, definitely. She has a history of hyperlipidemia, so she had really bad. She can have really bad fatty liver that eventually turns into hepatitis and eventually into cirrhosis. So yeah, so that all of that is like not really relevant to the case. That's kind of a tangent that we cut ourselves into. Any questions about that before we go back to the case? Dr. Khan is asking about jaundice. So yeah, if she had liver failure, you can have jaundice, which is yellowing of the eyes and the skin because of the bilirubin that gets built up in your blood. And we would probably be able to see that if it's bad enough. So yes. Dr. Ashton, I will get back to you on the adhesions and you'll probably answer that question for me. All right. So she denies any fevers at home, but she also has some chills. So Dr. Kashika, she's denying any fevers. What do you usually think of when you think of a fever?
I'm not exactly sure. I was thinking of either gastritis, pancreatitis, or cholecystitis, because for all three, a symptom is fever, and then sometimes there are also chills. And and she's also she also has a lot of the risk factors for cholecystitis because she's had several pregnancies, and she has hyperlipidemia, and one of the risk factors was a high fat diet. So I wasn't sure if that would be the same thing or if that's a cause.
Yeah. So that is definitely a risk factor. Do you know the other risk factors for gallstones and cholecystitis in general?
Yeah, also obesity and rapid weight loss, but I'm
Obesity,
not sure
rapid
about the
weight
rest
loss.
of them.
Yeah, so those are great. Those are actually the ones that I typically think of. When we think of patients that come into like the ER, what the mnemonic that we usually use is the 3 F's, but basically it's female, if they're obese, and fertile, meaning, but that's usually like around like 30s to 40 ages, or 40 is the other thing that people use. So those are typically what we would see for, or not the risk factors, but like the demographic of who we would see have gallstones. It's not really consistent. There's a ton of men that have gallstones, and there's people that are not overweight that have gallstones as well. So not super consistent, but that's what we typically see. So with a fever, though, yeah, what you're saying is right. But in general, we would usually think of like an infection or inflammation, right?
Mm-hmm.
So if she says that she has no fever, does that rule that out?
Does it rule out cholecystitis?
Does it rule out, well, cholecystitis, yes, but also like in general fever or inflammation?
If she doesn't have, well, I don't think so, not necessarily, because she might have a fever at the moment. She said she had no fever at home, right? So because we don't know her vitals right now.
Exactly. So she didn't have a fever at home, she thinks. Chills are a sign of infection or inflammation too, so that kind of tells us there might be something going on. The other thing is she took Tylenol. And so she was taking Tylenol to help with her pain. And so Tylenol will help with pain, but it also reduces their fever as well. And so that is definitely something that so she was taking it more for pain. That would reduce her temperature at home as well. So even if she came in with a normal temp here, we would want to still think of infection. All right. The last thing I was going to say about the fever is that if you fever a lot of times happens as your symptoms progress, and so if you have an acute issue going on, you won't necessarily mount a fever right away. That might take time, and so with that, I would probably think that if it's something that's very acute, she might not have had time to mount a fever, but she might mount it eventually. So you want to keep that in mind and keep an eye on that. And so you have to think of the chronicity of her symptoms as well. Does that make sense?
Yes, thank you.
Okay. And then somebody mentioned that Tylenol toxicity can cause liver problems. Yeah, it can cause hepatitis, and it can cause fulminant liver failure as well. So if you take a ton of Tylenol, you can basically kill off your liver. And so what we would want to do is maybe check some liver enzymes, but we'll get to that. Okay. All right. So I think we went over most of the review of systems as well, so I won't belabor the point. I was going to call on somebody. Forget who it was. So for her history of C-sections ×3, why is that important to know? And I cannot find the person who mentioned it. So if I said I was going to get back to you, this is who I'm getting back to.
Yeah, it was me.
Okay, sorry. Hey, so why is that important to know?
Because with each C-section, your risk of like infection and scar tissue and things like that is higher each time, and she's had 3. So it kind of made me think more about like adhesions building up and things like that, because those can cause blockages.
Good. So adhesions definitely, as you do more surgeries, as you muck around in the abdomen, you're going to cause the bowels to kind of stick to each other. And so if the bowels are sticking to each other and they can't move and contract like they normally will, you're going to have backup of your stool, and you're going to have basically a pseudo obstruction where there's not an actual mechanical obstruction, but there is, but the bowels aren't moving well enough to actually push the stool through. So definitely, what you mentioned about like increased risk of infection, yes, that is true. As you do more procedures and surgeries, you're going to have a higher risk of infection just because you're doing it more. The only thing is that, so for her, you're going to want to know when her last C-section was, and hers was about like 10 years before she presented. So do you think that would necessarily cause like her to have an acute infection right now? Probably.
I think with 10 years and things like that, there's still a risk, but I think she would have had those symptoms a lot earlier on.
Yeah, it's pretty unlikely. What we typically see is like a week out after a C-section, you're going to take a look and see if there's any like redness in the scar, or there's any drainage or anything like that. And those are typically the signs of an infection there. So, okay. So Dr. Sriram's asking, should we ask about any complications that might have occurred during the pregnancy? You can. It's been 10 years, so it's probably not super relevant, unless she had to have like a hysterectomy or something like taken out, or like a bowel perforation during the C-section. That would be relevant, but otherwise it's probably not. Okay. All right. So, okay. Dr. Nima, I'm going to go over some vitals. You let me know if you need me to repeat them, and I want you to interpret them for me. So blood pressure is 135/84, heart rate is 92, respiratory rate is 18, temp is 100.1, and O2 sat is 99 on room air.
Temp is a little elevated, I believe. What was the blood pressure again?
It was 135/84.
It's a little high.
Okay.
It should be 120/80.
Yeah. Why do you think it's high?
She's probably because of her pain levels.
Yeah.
But she
Yeah.
doesn't have fever.
She doesn't have a fever, but is that temp necessarily normal?
No, it's not. It's a little elevated.
Yeah, it's a little elevated. We know that she's taken Tylenol, like you mentioned before. So we would want to just keep an eye on it. Yeah, and so what about the heart rate? Is that elevated?
What's her heart rate again? Sorry.
92.
That's elevated as well.
Yeah. So it depends on what her normal is. Tachycardia would be above 100. But if we're looking at like, does she meet like SIRS criteria or the criteria for like systemic inflammatory response syndrome, they ask for above 90. So she would meet that criteria, but she doesn't. From her vitals, she doesn't meet any of the other criteria. So yeah, good job. So she just has a little bit elevated temp, though not a true fever, and then her blood pressure is a little elevated. Her heart rate's a little high too, though that might be because of her pain. All right, good job. All right, so the temp, Dr. Murray, was 100.1. All right, Dr. Sammer, what exams do you want to get?
I want to get a CBC, BMP, and maybe a liver functions test.
Okay, we drew them. They're pending. What physical exams do you want to get?
Oh, physical exams.
Yeah.
I want to maybe check out her abdomen, see if there's any signs of like tenderness or anything.
Good. Yeah. So she has tenderness and palpation of the right upper quadrant and epigastric region. She also has involuntary guarding with rebound noted in the right upper quadrant. So can you? So what are you thinking of with that?
So if she has some tenderness and guarding, that means that she has some type of pain that's going on. So she's trying to prevent that pain. So maybe her like muscles are kicking in to prevent that.
Yeah. So if she had let's take guarding first. So she has involuntary guarding, which means that her muscles are contracting because of some underlying inflammation. That is, and it's not because she's doing that. So that tells us that there's something more serious going on in that area. Does that make sense?
Yeah.
All right. What about the rebound? What can you explain what rebound is and what that tells us?
Rebound. So basically like when you're pressing down the skin or the muscle or whatever that you're pressing on, it's coming back up a little bit, and that could be from maybe like inflammation or something.
Yeah, so as we push down, it can cause pain, but as we let go, that will also cause pain as well, because you're having, the way that I think of it is like a motion wave that causes whatever underlying irritation in that abdominal cavity to get moved around and cause that sharp tight pain when you let go. So yeah, so that tells us that there's something more serious underlying that's causing some inflammation. And so rebound and guarding are peritoneal signs. It tells us that there's that peritoneum, so that lining around all the organs in the abdomen are starting to get inflamed. And so with that inflammation, you are going to have that tells us that one, there might be an infection, there might be a bleed, there can be a rupture of like of bowel or gallbladder or something along those lines. So it points to a more serious problem.
Yeah, and it's around like the liver region and the gallbladder region, maybe like part of the stomach. So it's probably related to those organs.
Yeah, exactly. Good job, Dr. Sriram. What's the next exam that you want to get?
Hello. Yeah.
Yeah.
Yeah, I would probably go for a Murphy's sign, or just like just palpate the entire region down, and and check for any pain which is elicited at a specific point in the
Yeah.
abdomen.
So can you explain what a Murphy sign is and what
So
is
you
it that
first
we're looking
ask the patient to breathe in completely,
for?
and then you palpate right below the ribs in the midcostal line, and and you see if the patient complains of pain.
Yeah.
And
So.
after that,
Uh-huh.
in case they do, then it's a proper sign of cholecystitis.
Yeah. So okay. So for those that you don't that don't know what a Murphy sign looks like, so if this is my rib angle here, this is the edge of my ribs. I get this part of my hand and put it right underneath those ribs. I tell that patient to breathe in, and as they're breathing in, I'm pushing up and in and upwards, trying to get to that gallbladder, right? So if their liver is right here, their gallbladder is sitting right underneath, so you want to push inside and upwards. And so as we're pushing in and upwards, we're advancing our hand towards the gallbladder. So as they breathe in, we're able to the abdomen becomes more like sunken in per se, and you're able to sink your hand in close to the gallbladder. Murphy sign is as you do that, as they breathe in, they abruptly stop. So you push in, they go, and they stop breathing because it's so painful. And so if they have that abrupt stop in breathing, that is a positive Murphy sign. And that indicates, like Dr. Sriram said, that there's something that is going on with the gallbladder or in that area, and it's typically more specific for the gallbladder. Does that make sense? Does anybody have questions about Murphy sign? Doesn't look like it. Okay, Dr. Sriram. She has no pain of palpation in the right lower quadrant or periumbilically. So what does that tell us?
But it's probably not related to the gallbladder in this case. Maybe it's like something more to do with the pancreas or stomach.
So right lower quadrant, periumbilical, is that specific to something? The periumbilical may be the pancreas, but what about the right lower quadrant?
Oh, right lower quadrant. Oh yeah, this appendicitis.
Yeah. So with appendicitis, a lot of times they'll say that they'll have tenderness around the belly button, so the umbilicus, and it'll go on for like maybe it can go on either for hours, a few days, and then it eventually migrates to the right lower quadrant, and that can cause pain. So definitely. So I heard there was a 50% chance of false negative for Murphy sign. I actually don't know the false negative rate, so I would have to look that up. And if you have a paper that you can send me, I would appreciate that. All of these tests you don't take as 100% yes or no. This is what's causing like their symptoms. You have to take it as an aggregate of their entire clinical picture. So even tests, like for instance, when we think of a DVT and we're palpating the calf and checking Homan sign, which is like where you bring the foot up and you're trying to see if that elicits pain in the calf, that usually will show you that there's a DVT. But I believe like the sensitivity of that is actually really weak. It's just that we do all these different tests to see if one of those pops up, and then the aggregate of them are a little bit better than just one individually. So I don't know if that made any sense, but I would always do a Murphy sign, even if it has a false negative rate, because that's just one portion of my exam. I hope that makes sense. Is there a high risk for false negative? Yeah, so I'd have to look that up. Appendix does not cause blood in the vomit. So yeah, appendicitis, you won't have bloody vomiting. This patient didn't have bloody vomiting either. It was just, it was non-bilious, non-bloody. But yeah, definitely, it wouldn't cause that. Okay. All right. Anything else that you guys want to get on the physical exam? I think that's pretty much all I had. In the case of appendicitis, why is the pain epigastric? So it's not. It's periumbilical. So with appendicitis, you'll have pain around the belly button, and it'll eventually migrate down to the right lower quadrant. So that's McBurney's point. The one in the right lower quadrant is McBurney's point. So bowel sounds, good. She has bowel sounds in all four quadrants. So Dr. Nabiha, The fact that she has bowel sounds in all four quadrants make what less likely?
That there's any bowel obstructions or any bleeds, I believe.
Good. Yeah, so it makes bowel obstruction. It makes bowel obstruction less likely. What would you hear if there was a bowel obstruction?
Maybe like I'm assuming gurgling sounds are like very like sparse sounding.
Yeah, you wouldn't really hear a ton of bowel sounds. If it's an obstruction, what you can sometimes have are these like tinkling and rushes, but it'll be generally harder to hear bowel sounds.
Would it be
Would
it be better if like felt it instead to feel for tenderness rather than like hearing for it? Would that be a better indicator of any obstruction, or would the sounds be better?
Honestly, the best thing would be an X-ray because that would be probably the most definitive. Both would be helpful. I don't think one is better than the other.
When would you guys decide to do that?
The X-ray?
No, the ultra. Would you guys ever do an abdomen ultrasound?
So if we're thinking of a bowel obstruction, an ultrasound won't be super helpful. The X-ray is more helpful because you're looking for air fluid levels. You're looking for the contents inside the bowels to kind of just sit there because they're not moving, and so you'll have kind of like a step ladder type appearance where there's just levels of like fluid all throughout the abdomen, and you can't really see that with an ultrasound per se.
Okay.
Okay. So, Dr. Sharma, what labs do you want to get?
I think that I would start with a full CBC and like check her white blood cell and hemoglobin levels.
Okay, so her white count's 12.5, her hemoglobin's 12, her platelets are 190.
So is her white blood cell kind of high?
Yeah, it's a little elevated.
So does that mean that she could still have an infection and like the fever that we were talking about earlier?
Yeah, definitely. She wasn't shown to have a true fever. She had elevated temp, but her white blood cell count is a little elevated, so that can definitely point towards a infection. Hemoglobin, platelets, anything notable there?
I think they were looking like okay. Can you repeat the hemoglobin levels?
It was 12, and the platelets are 190. They look okay.
Okay, cool.
Yeah. Any other labs you want to get?
Well, if there's an infection, maybe like a liver test, like a liver function test.
Good. So yeah. AST is 10, ALT is 17, T-Billy is 0.8. So AST, yeah, they all look good. What if I told you that the T-Billy was 1.8? What would you think?
She's having kidney issues?
The total bilirubin.
Oh. I'm not sure.
Okay, that's okay. So the bilirubin, I think, I don't know if I mentioned this in a previous video. It's Dr. Aruba, why don't you tell us? What does the T-Billy tell us? Okay, that's okay. Let's see. Dr. Megana, why don't you let us know what that means?
So a T-Billy is like a waste product in your body. So I think if there was some blockage in the liver, then it would increase the amount of bilirubin that was brought back, and it probably didn't excrete it.
Yeah, so if we're thinking of an obstructive process, like if we're thinking something like a gallstone that got lodged somewhere, or even like a pancreatic head cancer where that's basically blocking off the outflow of bile, that bile is going to start to build up, and in the bile that's being excreted is bilirubin, and so the bilirubin is no longer able to be excreted out and into the intestine, so it'll start to back up into the liver, and it'll start going back into the bloodstream, and it'll cause an elevation in bilirubin. And so, so Dr. Sexton is saying cirrhosis, but a lot of times with cirrhosis, you're not going to have a change in bilirubin because your liver's not really
functioning.
It's not really functioning. Actually, that's incorrect. I was thinking liver enzymes. So you wouldn't have a change in liver enzymes because the liver is basically scarred down and everything. You would still have an elevation in bilirubin. But the bilirubin, in this case, if we were thinking that it was elevated, if it was elevated, not so much in this case, we would be thinking that there's probably an obstruction lower down in the common bile duct. So good. All right, and so AST and ALT are normal, so that tells us that there's no acute inflammation of the liver. All right. Let's see here. What other labs do you want to get, Dr. Magano?
Probably a lipase test.
Okay, and
check for the pancreas injuries.
Yeah, so her lipase is 25, which is normal. So if her lipase was elevated, what would you be thinking of?
Maybe it could be due to alcohol consumption, but she said that she didn't have any alcohol use, or probably a gallstone.
Yeah, so if we're thinking gallstone in general, and then we see an elevated lipase, we start to think of gallstone pancreatitis as well. So the gallstone gets lodged in, and it's not able to push through that opening into the duodenum, so everything gets pushed back, including pushed back into the pancreas. And so so that would be something that we would want to evaluate pretty quickly and make sure that we take care of before we have worsening pancreatitis or before we have an infection within the common bile duct, so like cholangitis. Good. Anything else you guys want to get?
I'm not sure. What else?
Okay, that's pretty much it. The only other thing was her kidney function. So her BUN and her creatinine was normal, so 10.8, and those were within normal limits. A lot of times with somebody with acute vomiting, you do want to check the kidney function, because if they have a ton of vomiting, they become really dehydrated, and that can cause a kidney injury. All right. So does hyperlipidemia affect the risk of pancreatitis? It will if the triglycerides are significantly elevated. And so if the triglycerides are really, really, really high, you can have that be a cause of pancreatitis. And so you would maybe want to check that, but that isn't super common. A urine pregnancy test ruled out pregnancy before imaging, definitely. And hers was, I don't know if they got one on her. I didn't write it down. But we can assume it's negative. Do we check a CMP? So a CMP is basically the basic metabolic panel, so all the electrolytes, the BUN, the creatinine, plus the liver enzyme. So we basically did check it. Her electrolytes were all normal. All right. So who wants to summarize the case and tell me what they're thinking is most likely going on? And it's open to anybody.
I can try to do it.
All right.
Okay. So I think that she has cholecystitis because we said that Murphy's sign was positive. Is that like the terminology?
Yeah, Murphy's sign was positive.
And then her liver enzymes are normal, so that rules out some of the like liver issues. And then what else?
So what about her history? What in her history tells you that this is likely, like how she presented and all that? What is it? Why is that pointing towards cholecystitis versus other issues?
In my notes, I wrote that cholecystitis is more likely or more common in women and people over 40 years old, which is consistent with her.
Mm-hmm.
She also has like nausea and vomiting, which is consistent.
Yeah, good. And then the big thing is that she's having pain
In her upper abdomen.
in the upper abdomen. Exactly, in the upper abdomen after she eats, right?
Yes.
Good. And then you already mentioned the Murphy sign with the involuntary guarding, rebound, right upper quadrant pain. So all that points to cholecystitis. And then what about in her labs? Anything? And you mentioned normal LFTs. And yeah. So is there any modifiers you can put on for this patient? So you're saying she has cholecystitis, which I completely agree with. But is there anything else that she has because of the cholecystitis?
Maybe a gallstone. Is that what you mean?
Yeah. We would think that she might have a gallstone because of cholecystitis, and so we'd want to check that out. But what else?
I'm not sure.
Okay. So so we mentioned her heart rate being above 90, and her white blood cell count being above 12,000. Hers is 12,500. So what does that qualify her for?
Maybe some infection or like cancer, maybe.
So it definitely qualifies her for an infection. But is there a specific categorization of her syndrome right now? It's a lot of me asking you what I'm thinking. So
I'm not sure what it's called.
okay. So do you remember SIRS criteria that we had talked about that before? I don't. You might not have.
I don't remember. I'm sorry.
No, it's okay. So SIRS criteria is the systemic inflammatory response syndrome, and so that it's a specific criteria, and what to tell if there's systemic inflammation going on because of whatever underlying problem. So the temperature needs to be above 100.4 or below 96.8. She doesn't qualify for that. Heart rate is above 90, so that she does qualify for it. Respiratory rate above 20, which she doesn't qualify for, and then white blood cell count above 12,000 or below 4,000, and she does qualify for that. So 2 out of the 4 would qualify her for SIRS, and if she has a source for an infection, that is sepsis. So she's septic secondary to her cholecystitis. Does that make sense?
Yeah, thank you.
And the reason why that's important is because there's a bunch of things that we need to do within like the first hour that they come into the ER and all that stuff. We have to give antibiotics. We have to work them up pretty quickly because they're seen to be more sick than somebody with just a regular infection. So I agree with you. Definitely cholecystitis. What imaging do you want to get?
Sorry. I would want to get an ultrasound of her gallbladder because it's not as invasive and would give a good visualization, I think.
Good. Yeah. So I would get an ultrasound. And I think Dr. Saya said that she would consult surgery, and I would probably do the same thing too. So I would do the ultrasound, just like you said. It's less invasive. There's no radiation involved with it. It's pretty quick, and you can get pretty good visualization of the gallbladder with that. So her right upper quadrant ultrasounds showed pericholecystic fluid with a positive sonographic Murphy sign, no visualized stone, and I believe there was some thickened gallbladder wall as well. So pericholecystic fluid just basically means that there is fluid around the gallbladder. The thickened wall means that there's inflammation of the wall. A lot of times that's because of the blockage and the backflow and the pressure. And then the sonographic Murphy sign is exactly like we did with the Murphy sign, where we're pushing up and in, but they're doing it with the ultrasound probe. And then sometimes you don't visualize the stone because the stone passes before you're able to see it, or it's not a good exam because of body habitus or whatever it is. But typically, if there's a stone there, it's pretty easy to see. So for this patient, she was started on fluids. She got ceftriaxone and flagyl. Those are 2 antibiotics. And then surgery was consulted. She was taken to the OR, and her gallbladder was removed. So, yeah. And she recovered well and didn't really have issues after that. So, Dr. Khan is asking, isn't sepsis associated with low blood pressure? I thought her blood pressure was a bit elevated. So, yes. So, if you're thinking about septic shock or severe sepsis, you can have, those are different categorizations. Septic shock is when you have low blood pressure that's not responding to fluids. Severe sepsis is when you have end organ damage, like you have damage to your kidney, you have damage to other things. So you don't necessarily have to have low blood pressure to have sepsis, but as sepsis progresses and you have that systemic inflammation, you will start to have lower blood pressure. That's a good question. Why would physicians use a Hida scan as opposed to other imaging tests? So Hida scans are it's a test. It's a nuclear type test where you are you have a type of contrast agent that is going to be picked up by the imaging, and so you look to see if that contrast agent is being uptaked into the gallbladder, and so typically it'll go through the biliary tree, and so however the bile flows down out of the liver and eventually into the duodenum. And it'll look to see if that contrast agent goes into the gallbladder. If it doesn't, you know that there's an obstruction there, and so a positive Hida scan will tell us that there's something obstructing the gallbladder. We typically will use that if we can't get a good visualization of the on the ultrasound, or if we have a doubt that there's actually an obstruction there. So that's when we would typically use it. Okay. Okay. Then the bile flows directly into the intestine anytime the liver produces it. Thus, we need to change your diet. So, yeah. So as you remove the gallbladder, you're not going to have that bolus of bile going in every time you eat. So we're going to want her to change her diet. The risk of having another gallstone is pretty low, although I have seen gallstones happen in patients without a gallbladder, but it's not as common. But we would want her to change her diet for her own benefit. Could there be drainage issues later? So generally, it'll just be free-flowing bile from the liver. You won't have that bolus anymore. That's really the only difference. There might be some changes in her bowel habits that might be annoying for the patient, but they usually get better after a while. What's the difference between melena and hematochezia? So melena is when you have the blood from the upper abdomen getting mixed with the acid being broken down, and it travels through the gut and it causes a sticky black tarry type stool, versus hematochezia is more bright red blood. So Dr. Hannah helped. So thanks. Perfect. All right. Any other questions about this case? It was a little bit more straightforward, but I felt like it was good to have something a little bit more straightforward when you don't get as much information. Any questions? All right. Before you guys go, you guys can go if you have to. But I just want to talk about the next month and what to expect. So, like, as you guys all know, I'm going to be working in the hospital more. I'm basically going to be working 6 days a week. In the past, I'm going to be training the interns. So it'll be probably close to about 80 hours. So that's why I don't know if I'm going to have enough time to dedicate to build these cases out, get you guys materials out on time. And so that's why I sent that message to kind of postpone it for now. And so I'm going to go through the general schedule for the next 4 weeks. But first, Dr. Neem is asking, she just started this week, do you summarize the notes? So you don't have to upload anything right now. Whatever notes you have at the end, you don't have to summarize it. You don't have to make them look pretty. It's up to you, whatever you want to do, whatever is helpful to you. Just upload something at the end. That's all I care about to get credit. It's really for you. It's not for me, per se. So at the end, and it's going to probably be in about 3-4 weeks, you're going to have an assignment up there. You just upload it there, and that should be okay. So, so nothing is due right now this week. So no. So you're not going to have anything due for a few weeks, actually, because there hasn't been a ton of information that I sent out to you guys either. So I'm gonna give you guys more time to work on things. So next week, we're gonna go through a case together. It's the 4th of July, so those in the U.S., it's a holiday for us. I wanted to give you guys something instead of just saying no, there's no session that day. So we're gonna do a case together. It's gonna be a case that you haven't seen. It's gonna be a case I haven't seen, and so we're gonna solve it together. And you're gonna see a little bit of my thought process, and we're gonna work on your thought process as well on how do you go about it. So like that video I did for chest pain on how I went through the case is going to be similar to that. And so it's going to be open to everybody. There might, it's only going to be one case. There's probably going to be one session. And so I still have to think about if it's going to be Google Meet or YouTube. I'm assuming there's going to be more than 250 people. So it might be all on YouTube, but I'll have to think about that. So that's going to be next week. The week after, we're gonna have a Q&A type session. So I'm getting volunteers from people that are working in the medical field right now. So it's gonna be people that are in this class. So it's gonna be like EMTs. It's gonna be MAs. It'll be like phlebotomists and people that are doing research right now. People that are in master's programs. So have a kind of a good spectrum of the different paths you can take going into medicine, so you guys can ask them questions. It'll be kind of like a panel format, and then I can help moderate and answer questions that they might not know, or stuff like that too. So that one is also going to be voluntary, but it'll be better if more people show up so you can have more questions. So I do highly encourage you guys to be there. Then the 2 weeks after that, we are going to have 2 more cases. They're both going to be abdominal pain. I'll try to make one of the cases pediatrics, so I know people were asking for pediatric cases. The first session is going to be probably classes 1 through 4, and then classes 5 through 8 are going to be on YouTube, supporting and asking questions and being involved as much as they can. And I expect everybody to be there that day for whatever session you're assigned for. And then the week after, it's going to be flipped. So 5 through 8 here in the meeting, and then 1 through 4 will be on YouTube. And so it'll be 2 different cases. And so the reason why I'm doing it this way is because I'm working on Sundays every Sunday for the next month, as well as during the week. So I can't, and I'm going to be on call pretty much every 3rd or 4th day. So I'm not going to have time to do something on those Sundays. So so that's why it's going to be that way. Can everybody join that, or will it only be 1 person per group? Most likely everybody. I have to look at the logistics still and see like what the capacity is going to be like. I'm going to try my best to have everybody join, but I can't guarantee it. We have to still look at how it's going to work, but I will let you guys know. After that second case, most likely I'm going to end this cohort. And because we didn't go through everything that we wanted to do, we'll figure out a way to have you guys come back and be involved if you guys would like. So so we're still gonna figure that part out, but most likely at the end of July, we're gonna start over again. And I'm gonna be reusing some of the materials, but I'm gonna try to add new cases, so it's gonna be more fresh. Anybody who's using this for their med school apps or whatever, you'll still get full credit. You'll still, if anybody reaches out to me, I'll still tell them everything that we did and that you guys did great, all that stuff. So don't worry about that. Nothing that happened because of my schedule is going to affect you. So don't worry. I remember the questionnaire at the beginning asking if there's research endeavors. Is that still something you're thinking about and conducting? I am. It's just there has been no time. So I think it would be nice to have a general idea of how this went. and then go from there and to design something. So we still have a lot of time. I'm not planning to end these sessions completely, so we're still going to be able to do something out of it. It's just gonna, it's not going to be immediately. So, yeah. You still use 5 hours a week. If you're taking significantly more time to prep for the classes, just let me know what you're using, and you can put it on your apps. It's okay. I'm not going to necessarily police that. If you're saying that you're spending 20 hours a week, that's a bit too much. Then we probably have to talk about, actually, it'll be too much for this class, but be reasonable. If you're spending like 8 to 9 hours a week, that's okay. Yeah, so that's okay. All right, any other questions? Yeah, somebody in the last class mentioned that we should do a COVID case. I will try to do one. Honestly, there's not really much to do with the COVID case. It's relatively straightforward. I think one of the last cases in the chest pain was a COVID case. So if you guys really want, I can do one. But for me, it's not as interesting anymore. But that's just because I've seen it so much. Is a post quiz for the abdominal pain next week. It'll be at the end of the session, so it's not going to be till the end of July. We probably won't get great data out of it, but who knows? You guys did a lot better for the post quiz on chest pain, so we'll see. I'll keep trying to put out material for you on YouTube and explaining things a little bit better than just the readings, and so keep an eye out for that. And then keep studying, keep asking me questions, whatever you guys need help with, I'm here to help. I posted on TikTok about one-on-one mentoring sessions because I'm going to be commuting from, to and from the hospital. It's about an hour total every day. So I have a good number of people that sign up already. If you guys are interested, send me an email. I will give you guys a call when I go to work, and we can talk about whatever it is that you guys want to talk about regarding like your applications, getting into medicine, whatever it is. Yeah, I think that I haven't really seen anybody doing anything that we're doing. I know people are starting to do similar things in terms of like shadowing, but I haven't seen anything as with as much teaching. So yeah, I hope to be able to publish something out of it. Mostly probably in terms of teaching more medical decision making and how to think about like solving cases, not so much about the medicine itself, because I don't know if there's any programs that are teaching pre-meds that, and I think that it's something that we should teach, but yeah. All right, any other questions, guys? And if you think of something afterwards, you can always message me. So yeah, 5 hours a week is good. If you do more, like a few hours more than that, that's okay to put down on your app. But just don't inflate the numbers and don't do I would say don't do above 10 hours a week. That might be a bit too much. Okay. All right. If there's no other questions, I'm gonna let you guys go. And you guys are very welcome. Okay, so yeah, so if it was a 5 week, so 5 hours a week for 8 weeks, so it'd be about 40 hours. Yeah, so if you end up doing about 8 hours a week for 8 weeks, that'll be 64 hours. It really depends on whatever you use. So that's what I'm looking at also. When I restart the virtual rounds, getting a team together, we still have to figure out, what it is, what the roles are going to be. And so once we figure that out, we'll send out signups for it. Yes, I will send you your grades for the pre and post quiz for chest pain. There was a problem because of how the signups, so how the quizzes were taken, where we have to, I think, manually go and grade each one, which is unfortunate, but I will figure out a way to get it to you. I'll figure it out, but I will get it to you. I promise. I don't plan on necessarily stopping virtual rounds. I don't have an end date in sight. I do know that the rotation that I'm looking at is not going to be so much 8 weeks. It'll probably be 6 weeks, and we'll have 2-week blocks. So we'll have 2 weeks of we'll have 2 weeks of like chest pain, 2 weeks of abdominal pain, 2 weeks of something else, and go from there. Because there's a lot of new people that are going to be joining. It'll probably be the same topics, but I'll try to make the cases different. If there's more repeat people than new people, we'll consider doing new topics, but it'll all depend on my time too. So we'll play it by ear for now until we kind of figure out exactly what we want to do. If you join halfway through the rounds, we'd be able to be a part of the first part of next rounds. Yes, you can, but I would prefer that you be involved throughout the entire 6 weeks, not just the first half. So if you are going to be a part of the next cohort, just make sure you can commit to the 6 weeks. For the post quiz, you got a copy of the answers. You can, you guys got a copy. You guys aren't supposed to get a copy, but that's okay. Whatever. That's fine. Yeah. So you can watch the YouTube for the answers. I actually took down the post quiz answer session because I want to make sure that the integrity of the quiz is maintained, because I might use it in the future. So the UTHSC moved online. Can I share some insights about these sessions with the new students? I'm an alumni. I have contact with current tutors. Send me an email, Sydney, so we can talk about it. Were the results for the chest pain posted? There was a post quiz video which I unlisted because I want to make sure the answers aren't circulating, but they haven't been sent to you guys yet because I have to grade them individually, it looks like, but I will figure out a way to do it automatically and I'll send it to you guys. Any other questions you guys have? If not, I will let you guys go. All right. Take care, be safe, and send me a message if you guys have any questions about anything. All right. Bye.